Right, we want to buckle down now to a discussion with our panelists who are already here in studio. And today here on the Leadership Forum, we are focusing on the state of the universal healthcare in the country. And we know every year 1 million Kenyans are driven below the poverty line by healthcare-related expenditures. Poverty predisposes them to disease and slows all aspects of growth in the economy. Poor health hobbles economic growth, we know. Nobel laureate in economics Robert Fogel noted in 1993 that better diets, clothing, housing and quality healthcare all play an important role in generating growth, strengthening healthcare system to increase access to affordable, appropriate and quality health services in any country. And of course is a prerequisite for long-term development and structural transformation. Africa accounts for a quarter of the world's disease burden, but as less than 5% of the world's doctors, the continent lags far behind in basic healthcare coverage for services such as immunization, water and sanitation and family planning. Kenya is no exception. The new Kenyan constitution devolved responsibility for primary and secondary healthcare services to the newly demarcated 47 counties, leaving the national government to focus on policy and research. And of course, that is what we're going to be training our focus on here with our panelists. We have already in studio with us the panelists that I want to introduce to you momentarily, but we can head over to our Twitter handle. Our Twitter handle is AM Live in TV. Also, you can cross over to our profile name on Facebook, which is AM Live in TV as well, and 20505 is our SMS portal as well. Right, let's buckle down to a discussion with our panelists. We have with us in studio this morning Halima Adan. She's a theatre nurse. Also, we do have with us Dr. Walter Odhiambo, who is a consultant and chairman, Department of Oral and Maxillofacial Surgery, University of Nairobi. Also, we do have with us Dr. Mungai Ngugi, who is a urologist. We do have Peterson Wachira, who is the chairman or the national chairman of Kenya Union of Clinical Officers. Of course, we tried to get somebody from the medical board to be with us, but of course they pulled out at the last minute. But we want to drill deeper, looking at what we have as a state of the universal healthcare in the country. So much has been happening in the recent past, so we want to drill deep and find out how can we peel back the layers to see what is the problem and the niggling worry that many of you have as far as even the referral hospital is concerned. Good morning, gentlemen and lady.
Good morning. Good morning.
Right, so we've done stories, and of course we know what has been headlining on our dailies as well as far as Kenyatta National Hospital is concerned. If you look at the Daily Nation, that is a splash today. Of course, now even politics with it also is picking up. And we have, if I may just put it in perspective for you to see clearly, it says Ruto, CS in battle for the soul of KNH. Deputy President said to have asked MPs to go slow on CS. Politics of tribe has invaded Kenya's largest hospital, drawing the fury of Deputy President, who is fighting to have Sicily karaoke from the fangs of hostile MPs. This story is tucked away on page 4 and 5 of the Daily Nation today. Let's just begin from there. We don't know what is really happening right now. We understand the situation at the Kenyatta National Hospital is under investigation, so we won't really drill deeper from there. But from your own estimation, looking at the state of the universal healthcare in the country, how would you rate it right now? Let's begin with you, Halima.
I would rate it, how would you want me to rate it in terms of percentage?
No.
Like?
Just generally, if you focus, are we making any progress? Are we retrogressing? Yeah, not in terms of numbers.
Okay, I would say we are retrogressing.
We are retrogressing?
Yes, yes, because health was devolved under the new constitution, and we expected it to favor the common Wanjiko in the country. But when we look at it, we have a situation where all the 47 county governments are supposed to offer quality health care as per the constitution to the citizens. But last year, health workers all over the country went on strike like 80% of the days in the year. So that means there's something terribly wrong. I've just seen something on media right now that Homa Bay Medics and Siaya are on strike currently because of lack of payment, which is an indicator that there's something very wrong in the management of healthcare in this country.
All right, so we've been on this, and we know we don't know how we can have a convergence? Because it seems when the nurses now strike will be over, the doctors will pick up the baton, they will carry on with it. Then the doctors, after they're done with now the strikes, now the baton will pass over to the clinical officers as well. And so this seems not to be a very concerted effort as far as this strikes and the collective bargaining agreement are concerned. Why is there such a disjointed, approach when it comes to your welfare, you in the health sector? Let's hear from Dr. Odhiambo.
Good morning, viewers. I would say that the situation in health in our country has retrogressed. As she has rightly put it, there are a lot of factors that can indicate this.
Yes.
Of course, it's a difficult time for us medics to be here because we are on the headlines for the past 1 week for obviously wrong reasons. But that aside, if we leave the screaming headlines, you can just see, for example, recently in the last year, for example, the cholera outbreaks. These are very clear indicators to you of the state of our health. The other indicator that will tell you, will inform you about the situation of our health, is the number of citizens who go leave our country to India to seek treatment. And the reason is not because this treatment cannot be offered here, but rather because we have not managed our healthcare system well. Devolution, for example, of the healthcare was a very good idea aimed at improving access.
Yes.
And indeed, it did that for some counties.
Yes.
Some counties improved, like, for example, we were just sharing Makueni, what their governor is trying to do, is improving access. But because it was never structured properly, we ended up with strike day in, day out. We ended up with doctors not being paid their salaries, nurses not earning their salaries, no equipment. And even when the managed equipment service came about, where the government brought in 38 billion injected into the system, it was again never planned. The health personnel on the ground were not consulted, and you ended up with big machines in centers again that had no personnel. So I feel that our number one problem is the management of the healthcare system. And then number two, then we would go to financing it. But the number one is, how has it been managed? The doctors have been asking, for example, for the Health Service Commission, similar to Teacher Service Commission, for example, or Judicial Service Commission, to regulate the personnel. And this has not been done. But the national government, again, cannot sit back and say we have devolved the health, because, bad health, poor health has no boundaries. If there is a cholera outbreak in one county, it will not respect the boundaries of another county. And all this then brings in the national government into play. So ideally, I think our situation now is worse.
All right, so we cannot really uncouple national government, from the devolved system of healthcare as well, right?
Actually,
even if it's devolved.
Actually, drinking water, for example, ask yourself, the river flows from one county to another one. So if the river is contaminated in one county, don't expect that the next county, because it has all health parameters will be spared of an outbreak of a disease.
Right.
Yeah.
Okay, let us hear from Peterson Wachira as well. As far as the clinical officers are concerned, are we retrogressing? Are we progressing? And why don't we have a united voice? This is what I'm not hearing from also Walter and Halima as well. Also, maybe Professor Ngugi, Mungai Ngugi will tell us as well this morning.
Yeah, good morning. About the universal health care, I think the problem is a matter of approach. I want to say that for the presidency and the executive to see that universal health care needs to be one of the pillars, that is commendable. But then in the executive, we do not have the technocrats that are supposed to unbundle what a universal health care means. And this is now the role of the Ministry of Health. But you're asking, are we retrogressing? What I would say is that healthcare in Kenya is not stable. We are very unstable.
Yes.
And we are very unstable because our approach to the healthcare system in Kenya is upside down. And I'm saying this from the perspective of, in a good healthcare system, you need a preventive approach, a primary public healthcare that is responsive so that even before that patient comes to the hospital, there are some measures at the community level to prevent these diseases from coming on board, like cholera and other diseases. That is what we are lacking in Kenya, because we are focusing too much on curative, forgetting that for every case you get in a hospital, it's the failure of the public health system down there. So we are at ground zero, or actually negative, because we are very unstable. So it's upon the Ministry of Health to be able to stabilize the healthcare, so that from there now we can start looking at how do we offer this universal healthcare model. And even this universal healthcare model, then we need to see what is the approach we are using. If it's NHIF, is it universal healthcare really?
Yes.
Because that person in Kibera and Mathare, can they be able to afford the 500 they're supposed to pay for NHIF?
Yes.
Do we have some subsidy measures that we are putting in place so that we can be able to cushion such a person?
Yes.
And then we must look at the stability in terms of the building blocks. The building blocks for healthcare system. And this is in the leadership and governance. And in the leadership and governance, this is where you get the other building blocks like the financing. So, are we able to finance our healthcare system such that we can subsidize in such a way we can have universal healthcare?
Thank you, thank you. And of course, I'll give you also opportunity to also lay down some of the points that you do have comprehensively. You'll have 5 minutes each of you actually to walk over to the lectern to tell us more about this. But these are just opening remarks. Let's hear from you also, Professor Mungai Ngugi.
Yes, thank you, Debarl. Good morning, viewers. I think we've lamented for too long.
Yes.
We've been saying this will not work, this has not worked. And in my view, we should do what the Kenyans are doing. The Kenyan person, from wherever he is, looks at his health as his own responsibility. But the government has a coordinating role. What has the Kenyan done? One, the number of people who have been trained in various professions in this country is bigger than any other country in this region. That's a Kenyan initiative. It's not a government initiative, it's a Kenyan initiative. Kenyans have trained themselves in and outside this country to deal with health issues. So we have very high quality cadre of healthcare workers that sometimes are looked at as though they don't belong to this country. We tend to think of, let's say, the surgeon in KNH and somebody like that. He is not living in KNH, is he? He is not living in this world. He's seen as somebody alien. Those people are part and parcel of this country. The people who plan healthcare have not involved the healthcare workers in delivery of the health system. The delivery of the health system is left to people, I dare say, who have never learned what medicine is about, what healthcare is about. And when those are at the top of the delivery of the healthcare, you tend to have what can I get from this system approach, then what can I give to this system? Debarl, I would say, this country needs to look at health as belonging to everyone. When a governor had a road traffic accident, he did not go to the best hospital there was. He went to the nearest facility. So we must improve all our facilities in tandem with our needs. We need to ask ourselves what are our needs. So when you talk about universal healthcare, what is this universal healthcare? Yes. What are we talking about when we talk about universal healthcare? Can we isolate that to treating of TB or treating of HIV or treating of politically correct diseases?
Yeah.
Or should we look at universal healthcare as everybody accessing, like the other people have said, accessing healthcare, being affordable? If you go to Kenyatta National Hospital as a patient in an emergency, some people are on top of the bed, some people are below the bed, and others are on the bed. I do not know how you label that bed. Who is sitting on that bed? Who is lying on that bed? And you want this Jesus doctor to be able to tell the difference between the three people who are lying on that bed. Or a nurse. You have a nurse with 100 patients Teachers have a problem teaching 100 pupils. But you want a nurse to be able to know 100 patients by name, by their disease, and how to treat them, and not give the wrong injection or give the wrong treatment. If that's what everybody does. If you have a big problem, segment it into areas that you can deal with. Look at your easy, low-lying fruits that you can sort out, then deal with the big problems. Dr. here, my colleague at the university, has mentioned, for instance, the medical equipment services. What is the impact of these medical equipment services? I am, because I belong to the East Africa Kidney Institute, have been training for these people who are dialyzing in the country. What is the impact? And the one thing we do not do is ask ourselves, what is the health system doing? We do not, you must invest some little money into finding out the impact of the health delivery system. And that is what ails us.
Thank you. I think you've actually laid a good foundation, all of you. You're watching the Leadership Forum here on AM Live. And of course, today we train our focus on the state of universal healthcare in Kenya. We had continued, of course, with the conversation, the pace with our panelists before we took a short break. And right now we want to focus on the speeches they will present for us this morning. And first up on the lectern this morning is Professor Mungai Ngugi, who's a urologist and also a lecturer at the University of Nairobi. Professor, you have 5 minutes beginning now.
Very well. Thank you very much, Debarl. I think we have been, like I said earlier, mourning a lot, but we've got to look at the strides we've made to start with. This country appears to be almost conquering infection, even though we are getting cholera every now, so here and there. But I think the one thing we need to have is Kenyans being confident with what they have. Kenyans being confident with the Kenyan health worker. We've got some of the best trained brains in this part of the world. Our brains, when they go out there, do very well. What ails us is not the lack of personnel. It is the imagination that the health personnel are superhuman beings. They're not superhuman beings. They work and live with us. The Kenyan surgeon, for instance, is not one who is infallible if he does not have what it takes to do the surgery he's going to do in front of him. The Kenyan nurse is not a superhuman being. These are people who have very good brains, and this world has shown us, but what we need to do is to nurture them, take care of them. The Kenyan, I'm appealing, should stop throwing stones at the health worker. When everything goes wrong, we tend to throw stones at the health worker without asking ourselves what actually went wrong. This is a very easy approach to it. Rather than looking at the system, what is it in the system that makes our things go wrong? What is it in our system that makes a cholera outbreak happen? What is it in our system that makes me do the wrong operation? What is it in our system that makes me do an operation in a manner it was not destined to be? That system, the looking at the system, is what I would look the Ministry of Health to look at. How do you streamline systems? How do we arrive at decisions on our needs? For instance, this country has done very well in terms of rolling out dialysis all over the country. 34 counties out of the 47 can dialyze patients who would otherwise have died. But we need to ask ourselves, what kind of workload do the people delivering this have where they are? Are they given the best opportunity? And recognize the health worker. Let's not abuse them. Let's not insult them. And most importantly, don't sack them at the whim. Don't just wake up one day and write a letter because my patient has died. Patients die every day. Patients get injured every day. The question we should be asking ourselves is, why should we have 3 patients on a bed? How will that healthcare worker identify these patients? Why should I see 300 patients in a clinic? Is it humanly possible? Kenyans want the best. They demand the best, and they should be given the best. But we are training the best. What we need to do is focus our resources. There are certain things we probably don't need to be very good at. Let's excel where we can do our best. Where we are not sure what we want to do, we should not struggle. Go back there, study, research. But healthcare delivery in this country will be delivered by the people of this country. There has been a notion that you can bring some people from Mars to come and deliver healthcare in this country. You can bring people from wherever, but you will not be. Now, the other question is devolution, the devolution of health services. How has it been done? What is this story we are hearing that the devolved units treat health workers as though they are, well, clearly, they're houseboys and housegirls? These are extremely well-trained people. You see the people who do KCP, Kenya Secondary Education, they're the best brains this country has. If they're the best brains, why do you want to abuse them? The people who've got to do KMTC and whatever, they have got the best grades. So why do we want to think that these people are bad when we employ them? What we need to do as a policy, the government of Kenya needs to make, as a policy, popularize the people who work under very difficult circumstances. These are the only people who will work for 24 hours without asking for an extra pay, without saying they are tired, and report after going home at 6 a.m., report at 8 a.m. once again. Mistakes will happen because of that. So the government and the people of Kenya, whether it is in the national public institutions or in the private institutions, make sure that we have maximum working hours. No, we're not asking for maximum working hours. Why should somebody work for 36 hours? What human being is? We are worried about our drivers driving on the road for 36 hours, but we are not worried about our health workers being with patients for 36 hours. I think we should move in that direction. Thank you, Debarl.
Thank you very much. Thank you, Professor Mungai Ngugi there. And of course, he raises salient points that we should take note of. Kenyans, you should stop throwing stones at the health worker, drill deep and know what are the reasons and what is in our system that is making us also maybe do the wrong operation. Do we have the proper structures within our system? Also recognize the health worker. Devolution of the health services, what has been done, we need to also to probe that deeply. Is it working for the devolved governments as well? And of course, we shall be talking about this and a lot of other issues as well. And of course, if you have a question, a contribution that you want to make, you can head over to our Twitter handle as well for your contribution, or on our Facebook page, which is MLive and TV as well. We have with us as well Peterson Wachira. He's a national chairman, Kenya Union of Clinical Officers, and also former team leader, Ebola volunteers in Sierra Leone. He's here to tell us more about what he thinks about the universal healthcare in the country, especially from the clinical officer's perspective. Peterson, you have 5 minutes beginning now.
Thank you. And good morning, Kenyans. I want to start by agreeing with Kenyans that there is something wrong with our healthcare system as of today. Also, I want to appreciate that the Kenyan population is getting increasingly concerned about their healthcare. And this is what they should do, because they are obligated to take their government to task. Because universal health care is not a privilege from the government to the mwananchi. It's a right that has been given in the Constitution under Article 43A that gives Kenyans the right to the highest attainable health care. Having said that, I think what we have seen of late about Kenyans condemning their health workers is from a point of lack of sensitization or misinformation on the state of health in this country. Because as a Kenyan, as Wanjiko out there, I expect that the healthcare system should work for me, but it doesn't. And we have to look at the realities that we have as health workers, even as we are working back there. To start with, like now we have clinical officers in Homa Bay and Siaya. They are on strike because they have not been paid for the last 2 months. And that is why we are saying that we must start by stabilizing the healthcare system so that when we are at ground zero, then we can discuss on how we are going to go forward and deliver this universal healthcare. For us to be able to stabilize, there are several things that we must look at. One of the things is the leadership and governance. And while looking at the leadership and governance, then we must look at the health financing. Kenya is a signatory to the Abuja Declaration that said that for us to have a better health system, we need to set aside 15% of our budgetary allocation to the health sector. And why do we need to do this? Because for you to have a responsive and effective healthcare system, you need to have enough health workers per the WHO standards, whether we are talking about the 23 workers per 10,000 in the population, whether we are talking about 40 clinicians per 100,000, it needs financing to be able to recruit these health workers and to recruit them in their right mix. Because you cannot have one cadre and then you assume that you are delivering healthcare to the Kenyan populace. Then, still on financing, you need financing for you to be able to provide the essential medicines and technologies. We are still at a point where the model universal health care we are giving using NHIF still limits most of the health workers from even prescribing diagnostic procedures and even imaging based on the cost. And this then limits the access to these essential technologies that are supposed to give a proper diagnosis to Wanjiku so that they can enjoy the highest standards of health as guaranteed in the Constitution. Then other things like even information systems. So for us to be able to stabilize, we need a leadership and governance that is responsive and that understands, as Dr. said, what healthcare is all about. Then having the right leadership will have the right workforce on the ground, and it should be right in terms of expertise and the numbers on the ground. From there, we'll have stabilized. After we stabilize, then we need to look at the approach we are using in the healthcare. We need to revamp our preventive strategies, the public health strategies on the ground, where we can be able to even cap the numbers coming to our facilities. Because the problems we are having in KNH, and it's so unfortunate that we have now all realized that we actually don't have enough workforce at KNH. We have been relying on people who are back there to learn, the students, per se, if I may say so. Though we all know that they are not students, they are just advancing. But they are not employees of Kenyatta National Hospital. So if we cannot even be able to have the right workforce in our highest referral system, then what are we doing as a country? How do we then even start talking about progressing when we do not have the basics? So my clarion call will be to the parliament and the whole leadership and governance, including the executive, which then includes also the CS and the leadership of the Ministry of Health, that we must stop looking at healthcare as an investment that is going to bring out output in terms of money. The only investment you give in the healthcare gives you output in terms of effectiveness in healthcare service delivery, and then it will give you a healthy population. And then the man hours will not be lost, and even the economy can be able to progress. So my clarion call is that the parliament and the executive, they need to sit and rethink the strategies, especially in health financing, so that we can be able to achieve the universal health care that we are talking about. And Kenyan population, they must take their leaders into account because they have been given unlimited rights and they must claim it. Thank you.
Thank you, Peterson Wachira. So you have it there. You have to take your leaders to account. He says from that particular presentation this morning, universal healthcare is not a privilege from government. It is your right, enshrined and codified in the Constitution. Also, lack of sensitization and awareness also is perpetrating these ills that we have in the health sector as well. So how do we get to stabilize the health sector? He says leadership and governance also is paramount. Revamping some of our strategies like the preventative strategies, and you talked about also the curative strategy as well. We'll hear more from him as we get to also try and drill deeper on these salient points that they've just raised this morning. Thank you very much. We have up next Dr. Walter Odhiambo, who is a consultant and the chairman, Department of Oral and Maxillofacial Surgery, University of Nairobi. Is going to tell us also from his own perspective what is ailing our system, our health system in this country, and how do we get to up the ante as far as the universal health care is concerned in the country. Walter, you have 5 minutes beginning now.
Good morning, Kenyans. Thank you, Debarl, for asking me to come to your studios to talk about universal healthcare or the state of healthcare in our country. First of all and foremost, we have to understand what WHO defines as health, as the state of physical, social, and mental well-being. Is simply not absence of disease. But Kenya as a whole made some progress way back, and we can see that nearly all of us wash our hands when we are going to eat something. And basically, health starts from that kind of basics. Health starts from the very basics of our lifestyle. And this starts from the kind of food we eat, the kind of water we drink, and generally our lifestyles, whether we exercise. If we do all these things right, we need very little in terms of the amount of money we use in curative services, which is where our focus has always been. At this point in time, it's very difficult for us to defend health when we are on the headlines for all the wrong reasons. Mm-hmm. But it is also good for us because these headlines were foreseen. When the doctor strike last year was going on for 100 days, one of the key factors they were talking about was the work environment. And it is unfortunate that the first place to explode is Kenyatta National Hospital. But this was foreseen. Dr. Oluga, who was the leader of the KMPDU, came here over several times talking about the work environment. And if we do not address that, the situation will still go back to ground zero. Just as Professor Ngugi has said here, we can throw stones as health workers over one issue like what happened in Kenyatta the other day, but that will not solve our problems. Our first and foremost issue is to ask ourselves, where is Kenya going wrong in terms of healthcare? We decided to devolve the healthcare, but the doctors asked, can we have the Health Service Commission to regulate the staffing of these institutions? This was never done. We still have every county hospital wanted to have an MRI. They all wanted to have a CT scan machine, but they did not have even a single specialist to manage these things. So in a way, we were doing things, putting the cart ahead of the horse. Instead of putting structures on the ground, getting proper personnel, compensating them well, we decided to go and bring things, machines, big ones. But I think largely because it is easy to get a cut from this machine, unfortunately. And it is not easy to get a cut from what you are paying the doctors. So ideally, we need to get our health workers well compensated. That aside, I would like to say, for example, that several issues affect health. Health cannot be in isolation. If you look at, for example, the cases of road traffic crashes, which last year again hit the roof, and as usual, Kenya had a knee-jerk reaction in terms of managing road traffic crashes. But Kenyatta National Hospital, for example, Ward 6, where Professor Ngugi referred to, patients are on top of each other. Why? Because the number of people getting injured on motorcycles, in motor vehicles are enormous. But what do we do about it? You will watch motorcycles riding around here. There is an act, but they drive past the policemen with no helmets, carrying 3 passengers, carrying a goat behind, and so on. Ideally, we need to get this act together. Social order. Health cannot exist where there is total social disorder. If our waters are contaminated, if we live with the garbage in our houses, if our garbage are not collected, do not expect health. So ideally, the hospitals will be there, but I think as a nation, the issues that we have to address are starting from the basics. The cancer problem that we are now saying is an epidemic. A lot of it, we are complaining that we are eating toxins. We are drinking contaminated water. We are eating contaminated foods. But we are not addressing that. We are everybody is bringing cancer treatment machine. Everybody here, this county has now brought a machine, this county has now bought a machine, but they don't have oncologists. So I don't know whether the machines will treat the patients, I don't understand. But then again, Kenyans need to know that diseases like cancer are actually not curable, as they are largely preventable. If a high-profile person like Steve Jobs, with all his resources, succumbed to cancer, Steve Jobs had access to all possible finances, all possible specialists, but he still succumbed to pancreatic cancer. So the idea is that, what am I saying? let us invest on preventive programs. But to conclude, Debarl, I would also like to remind Kenyans that specialists are here. We do not lack specialists. All these surgeries that we want to be done outside, and you had, for example, the unfortunate case of Louis Otieno, where Professor Macharia came up, an ENT specialist, who is my teacher,
yes,
came up and said, we can manage this condition here. Why aren't we managing them here? It's because we have not financed our healthcare system well. And to conclude, I wish to say, to add that our leaders, especially the political leaders, if they give us example by equipping our health facilities, and then there is sick treatment there.
yes,
All over the world, university teaching hospitals is where the presidents are treated. They go there because that is where the facility is. So let us look at that. Thank you very much.
Thank you. And of course, we shall be picking up on those salient points raised by Dr. Walter Odhiambo. Up next, we have Halima. And as I'll just pick up some of the points that the doctor was talking about before Halima gets to the lectern. Regulation, or to regulate the staffing of institutions in this country, also that is very key. Specialists, we don't have enough specialists in the country. He's mentioned, of course, the oncologists who are far and in between, of course. In various counties, we have machines. People are really gagging for machines, but now we don't have specialists to operate these particular machines, and we're given to understand most of these machines, not even in the National Referral Hospital, are being used because of lack of specialists. So are we putting the horses before the cart before the horse? That is what the problem question that we should be asking ourselves. Also, we need to invest in preventive on programs, especially when we're talking about curative and also preventive programs as well. So compensation of the health worker is pivotal as well, and we shall be drilling deeper on this as well. We have Halima Adan, who's on the lectern right now. She's a theatre nurse, and she's going to also give us a scope of what really happens within her department of nursing. Why are nursing always striking every now and then? Halima.
Thank you very much, Debarl. Good morning, Kenyans. Section 43 of our Constitution talks of social and economic rights, and it gives Kenyans a right to highest attainable health care. In this country, we voted in the new Constitution, and Kenyans' health was devolved. Devolution has worked in some counties, and in others it has not worked. The government, from the executive parliament, from the Ministry of Devolution, Council of Governors, have a role to play in managing healthcare services in this country. And it is a collective role that cannot be done by one arm of government. I would say, from the nurses' point of view, that, like my colleague said, health has three components: preventive, promotive, and curative. We are seeing a situation where we are moving to the curative and avoiding the preventive. Recently, data released by WHO said that out of 100,000 births, 488 mothers are dying. And WHO started something about empowering nurses, because they're the ones who take care of antenatal mothers, pregnant mothers. We've seen the First Lady of this country trying to do that through Beyond Zero, but it is still not working, because those deaths should be going down, but instead they're going up. We need to employ nurses and doctors and other health workers. Currently, governments, the county governments and the national governments, are employing nurses on casual basis, contractual basis. Employment of casual workers is supposed to be done to services that are not supposed to go on for long. But healthcare services, people are supposed to be employed on permanent and pensionable. And if it's on contract, it should be at the same amounts that you're paying the permanent and pensionable staff. This morning, I was heartbroken to see an advert from Kiambu advertising for casual employment. These nurses, clinical officers are employed at 800, 1,000 shillings. The same amounts you will pay a mother who comes to your house to clean your dishes or clothes. Where are we headed as a country? You employ contract workers or locum workers at KNH as nurses. They will come in today, tomorrow they'll go to another hospital that is paying better. So who is taking responsibility for these patients? Worldwide, there is a certain age nurses get to, and you're not supposed to put them on night duty. Remember, these are workers who are underpaid based on the strikes that we've been seeing recently. So a 55-year-old nurse, age retirement is now at 60, with hypertension, diabetes, probably involved in an accident, has a stocking on her leg, she cannot walk, and you expect that nurse to manage 100 patients in a ward in Kenyatta Hospital. Are we really working towards improving health or towards killing Kenyans? And when there is a mess somewhere, there is an error, you go ahead and blame and interdict the medics. It is not right. We need to do the right things from us as medics and the system as a whole. We need to have an independent auditors to come and check how are we faring on in terms of health service delivery in this country. Because the people up there, whether at the Ministry of Health or at the counties, are appointed based on their tribe, it's unfortunate to say, and not based on competency. We need competent people, people who will be put through appraisals. If you don't perform, go home. Let others come in. Let's have indicators. What is it that, I'll give an example of Makueni County. They have access, they are giving their people universal health coverage. People paying 500 shillings and they just walk into a hospital and get services. I'll also commend my county that recently employed, Machakos County, 800 nurses. So this government has money. Can all counties look at the ratios? What is the ratio of a nurse to a patient? What is the ratio of a doctor to a patient? Can we at least get to above 60%? Because currently, probably we are at 10%. One nurse, according to WHO, is supposed to nurse 100 patients. But the study that was done in 2014, I think, showed 1 to 250. Probably right now, it is worse, because when the equipments were brought, patients are now moving because the hospitals have been painted. We have tiles all over on the floors. We have equipments that don't have people to man. So people are coming to access those services from all over and congesting these hospitals. But the staffing ratios are still below par. So what is happening? Errors. Errors that health workers could have prevented if they are employed in the right ratios. Can we also invest in research? Let's have a team that is going to look at worldwide what is happening. Where has health succeeded? What have they done to succeed? Can we copy something and model it into our country? We need to have the right people at those offices for us to. I'll not finish without talking about the Health Act, which was recently passed by the president. It was signed. That Health Act is discriminatory to the nurses and other health workers. We need to look at the concerns raised by these bodies representing nurses, clinical officers, and others, because these are, in healthcare system, you will not achieve anything single-handedly. It has to be team. A team entails everyone, including the cleaners. So we need to look at everything, and probably when we all work together, we are going to have the best for our people in the country. Thank you. Right.
So how are we approaching those? Some of the three-pronged approaches that we've had from Halima this morning on prevention and promotion and the curative strategies. Are we going full circle in terms of trying to make sure that we have a very robust health system in this country? Also, casual basis. Why do we employ our nurses on casual basis? These are questions that are, yes, are paramount, that we should be also getting proper answers from the concerned ministry. And of course, Health Act. We want to know how is it discriminatory, and we'll hear from Halima much later in the course of the program. But also to just go back to our discussion, we have also bites from some of the prominent leaders in the health sector, former also CS Minister Mailu, and also leaders from the nurses community as well. Let's just listen in a bit.
What is failing the institution, and this I've discussed with the CEO, is the issue of CSSD. Sterilization, because the items they use in theater after use must be sterilized so that they can be taken back to theater.
There are three critical people who must assess a patient prior to theater. The first person who must see this patient is the person who is actually going to conduct that surgery. The anesthetist who is going to administer the anesthetic drugs must come, assess this patient, and make note that actually this patient will go to theater and is able to sustain anesthetic drugs. This assessment must take place in the ward before the patient is wheeled to theater. So the issue of patient identification, if it is wrong, are you telling me that these doctors are just they're just operating on like robots? Are they robots? That they're just in theater, static in theater, waiting for bodies to come?
Problem question there from Panyako. We have reactions as well on social media. Abdallah Mdambo is saying, in Kenya we have put priority in the wrong places. Our healthcare is pathetic, to say the least. Our education system is full of endless tracks. Service delivery should be a priority. It should be what we fight for. Also, we have Oscar saying that, no, I disagree on that. We have all it takes. We got people who can manage very well. Let's stop politicizing it. Give time frame, and the person given this section, let him or her do the work. That's all. Give them time to prove otherwise. Also, we have Gashemi. Everyone should be accountable. So excusing mediocrity, especially where lives are at stake, feeds negligence, he says. Also, we have Jacob Abere Mtalala saying that my remedies to maladies that are ailing our medical industry are prudent medical supplying, goodwill from central government to counties in procurement systems, also public and private partnership campaigns about healthy living, and also we have NASA activists. What makes for a good health system? The probing question there. What makes a health system fair? How do we know whether a health system is performing as well as it could? And CS Kariuki, this question should be the subject of public debate in Kenya. That is what the NAS activists are saying. Also, Anthony Mwatu Mutie, universal healthcare is not a privilege for anyone, it is a right, and so is good nutrition care. Bring a nutritionist on board next time. That is what also Anthony is saying. I've taken cognizance of that as well. And we have Innocent, he's saying, ask Peterson why clinical interns 2017-2018 have not been paid even though the bill was passed. So that one also you'll have to tell us this morning as well. I have Kaingu saying it is very disappointing that health workers give good service to common Wanjiku, but their welfare are not well taken care of. For instance, some counties don't offer comprehensive NHIF cover to the healthcare workers despite contributing the maximum amount to NHIF as well. So let's just drill deeper on some of these concerns that Wananchi are raising. And of course, they will have a moment also to call in, ask questions and share contributions. We begin with you, Professor, because you are the one who started. And you ask a very probing question. What is in our system that is making us do the wrong operation? What is wrong with our system? Do we have a broken health system in this country? And what is a prime remedy?
Well, there was a person there a few minutes ago who was asking how does the identity of the patient fail. Actually, if you have 3 patients on one bed, John, Charles, and Abdi, who is the patient? The first thing we must do, facilities must be commensurate with the needs. That's the first thing. 2, the training. And this is where devolution is failing, let me tell you.
Yes.
Devolution is failing because if Onyango is working in Nyeri, I'll tell you this as a fact, that does not mean it's about this thing. If Onyango is working in Nyeri, he will not be sponsored to come and train. And that, Halima has talked about the tribalism messing our system. So, what's the best thing we could do? There are certain level of health worker training that must take place at the national level, not at the counties. The counties do not even know what they don't need. That's the biggest problem. So you have, I dare say, the governors, whoever they are, they don't know what it takes to provide service. So Kenyatta National Hospital continues to receive patients from far and wide in spite of having invested in equipment at those centers, because those people there have not invested in the personnel. They will sack their people. A lot of the surgeons, whoever, ran away when they realized. You've seen Dr. Ongech, my good friend here, saying, I'm not going to take up this post and be killed for a service that I cannot be able to deliver. Doctors are saying, we know what to do. Allow us to do it. The nurses are saying, we have a way of doing things as systematic. So, for instance, how do you prevent a patient from being wrongly labeled? Label this patient at the entry to the hospital.
But
why label just when he's going to theater? How will you tell? I mean, if you have cars out there and you have keys to every car, you'll drive any. So I think one of the things we need to do, this has happened everywhere. It has happened in Bristol, it happened in Tanzania, it happened all over. What we need to know is not blame the health worker, but devise systems that safeguard the right of the health worker. Doesn't mean the health worker is not a citizen of Kenya. We need to identify these patients when they're entering the hospital, when they're going to theater, and when they're leaving theater. Some of the surgeons that were involved in this patient, let's say frankly, are some of the best brains that this country has. Mm-hmm. We must look at making them feel appreciated.
All right, but whose problem is it? Is it our problem to actually
it's
label
systems.
These systems? Then we have Peterson talking about leadership and governance, right? So when you talk about system, where do we put the system? Is it in leadership and governance?
It is in leadership and governance. That's why we should get it first. In leadership and governance, if you're going to be the leader of a hospital, you must have a proven track record of managing similar institutions. And how does this go? You start with a kiosk, the smaller institution. You go up the ladder and you show you're managing well.
Yes.
You don't start from the top, and you have learned how to do it. That's one. Two, continuous training. As a doctor, I'm required to have continuous training, and we do. But the leadership has no continuous training at all because they have no need for it. We need to tell them that you are not born with information. You acquire it as you go. I tell people, information is not congenital. So they need to be taught, they need to learn, like Halima said, from other systems. What is it that was instituted in Bristol when they removed the wrong kidney? What was done? So that we need to learn from other industries. How do pilots prevent crashes? How does the nuclear industry prevent crashes? Those are areas we could learn from. In other words, the person who becomes the leader of an organization must be one who is capable of interrogating. Reading about it must be somebody who is able to read, recording what you have, and most importantly, auditing. You will find a mishap didn't happen because somebody has taken care. Right. And then you use that as a preventive.
Right. Let's say from Peterson, you raise the issue of we have a very unstable, healthcare system in this country. You want to qualify that. What are some of the parameters that you are looking at, that you're seeing there we are actually failing on this?
So the instability in healthcare is brought about by several issues. To start with, and allow me to start by answering the question that I was asked directly by, I believe, one of our interns.
Yeah, that's one of the instability we're talking about. You're not paying the interns as well.
Yeah, and this is because there is a lot of discrimination and iniquity, as my friend Halima said, in the Ministry of Health. From the legislation itself, the Health Act, and to even how things have been done. Clinical officers started training in this country in 1928. They have been doing internship, which is compulsory by law. That is, after you graduate, you get your certificate. You have 1 year mandatory that you must be an intern in a facility. They used to be paid until 1999 when they stopped without any reason. The other interns, all the other interns that do compulsory internship in the Ministry of Health, being the doctors, the nurses, and even the degree clinical officers, are paid. They have been paid without any policy, without any written document to guide. But when we ask the ministry to be able to pay the diploma interns, we are told that there lacks a policy to pay them. And then we ask them, then how are you paying the others if you don't have a policy to pay the interns?
All right.
And we have seen deliberate efforts to ensure that this is not done.
Thank you.
We have gone to court.
Yes.
The court has directed they be paid, and the ministry has refused.
All right.
The other...
Yeah, today I want us to focus on the wananchi. No, now it is, I don't want just you to take this opportunity to actually come and bellyache about your issues. I know, but you've addressed it sufficiently. Just finish up on what we were talking about, leadership and governance. What really seems to be cause of interest of time as well.
Yeah, so the instability in the health sector is brought, we can look at it from the aspect of the health workforce. As we said, we have a very acute shortage. But then, instead of us looking at how we are going to recruit and give them security security in their jobs so that they can be able to deliver well, then we are, as Halima said, we are employing them on casual basis and even some contracts that are irregular, even according to the PSC Act. Then the other bit is we are not even able to remunerate them to pay. To pay when they are supposed to be paid, so that we don't have instability when we have disruption of the services.
Okay.
And then, Dr. said here that we are training enough health workforce. But I think that is not very correct. Because like now, as we talk today, we have about 7,000 unemployed clinical officers out there. The ministry will tell you that they have an acute shortage. They will give you norms that will tell you that they were supposed to have employed 16,000 clinical officers by now.
Yes.
But yet we have 7,000 unemployed, and the ministry tells you that they don't have enough clinical officers. So the disconnect that you have.
Thank you. So there is an issue of communication as well, right? We shall address that. Let's say from Walton, then we'll take our callers who are hanging on the line very briefly.
Yes. Let me. I just wanted to comment about what Professor Ngugi commented about with regard to the mix-up, for example, that occurred at our hospital, which you have said is a matter which maybe we should not discuss. But I wanted just to say that let Kenyans know first that no surgeon, I'm a surgeon, and no surgeon is happy when a patient does not get the best health that they expected. No surgeon is also happy to be on the headlines for the wrong reasons. Fortunately, previously, the surgeons were also on the headlines for the good reason, like when they put back the hands of the boy from Kiambu.
Yes.
And that was good. And when surgeons, again, the very neurosurgeons separated twins last year. Mm-hmm. So there are several other good things that the doctors do. What Kenyans should know, for example, is that I say that KNPDU, which is the union of doctors, raised these issues in the strike last year. One of them was the congestion in Kenyatta National Hospital. Heavy congestion. Kenyatta National Hospital is actually, the bed capacity is exceeded by over 100%. In other words, it's admitting twice the numbers it's supposed to have in its facility. It is understaffed. Mm-hmm. The nursing, as I've been saying by Halima here, that the nurses are overworked, and if you do not expect lapses in that kind of situation, you are thinking that you are dealing with robots or not. You are not dealing with human beings. So the first step here is to say, why did we allow our national referral hospital to be so super congested that patients' management then is compromised? And this is an example of compromised patient management based on the facility, based on staff shortages, based on an environment where you have fewer equipments than you need. And that is why people are saying, for example, that how come patients are not tagged or labeled right from the time they enter the hospital, so that the tracking system is very good. Here are patients who go to the X-ray department. If they are unconscious, they are wheeled to the X-ray department. Right. The imaging person does the work, takes the images, expect it to be labeled properly so that you can actually get good outcome.
Thank you.
And so that is really what we need to look at. In terms of issues of health management at the basic level, I can say that we are still very disjointed.
Thank you.
And you have to look at that.
Thank you. Yeah, we need to take just one or two callers who are hanging on the line. Then I'll be remiss if we don't also talk about universal healthcare, elaborately, to just make sure the Mwananchi also understand what we're really talking about. Is it still about financing itself, or there are other prongs into it as well, bearing the fact also we are strapped for time. But we have callers who are hanging on the line. Let's just pick up our first caller if he's still hanging on the line. Good morning. Hello, good morning. Hello, do we have a caller hanging on the line, please? Well, we can't hear you from the floor. Maybe Matthew, the sound engineer, may help us so that we can hear Matthew. Good morning, Matthew.
Yeah, good morning, Debarl.
Morning to you, yes, we can hear you now. You have a question or a contribution, please?
This is Matthew from Garissa.
Yes.
And I've got 3 issues to talk about.
Yes, let's pick one only.
Yeah, we have the issue of tribalism in employment.
Yes.
Whereby people who are employed to work they are not competent.
Yes.
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 And then you find that's why you find the issues are arising in the ward maybe or in the hospital. Another thing we have is the NHIF.
Yes.
Why can the government allocate the NHIF money for the people instead of allocating this money to work in the hospitals to fight the drugs? It means that people are allocating money for the private facilities because it has never worked in the public hospitals.
All right.
Another thing we have is the insecurity.
Yes.
The insecurity we're talking about is when you find a nurse is working maybe or a clinical is working in a very insecure place, whereby even the police officers have been withdrawn and the teachers have been withdrawn from that place, then you find that a nurse is just pushed to work in that place or a clinic officer. What can we do about this?
Thank you. Thank you very much. We have another caller hanging on the line. Good morning. Edward, good morning. You're hanging on the line. Edward from Eldoret, good morning.
Hello.
Yes, we can hear you. You have a question or a contribution very briefly, sir?
Yes, I have.
Yes, please. Go for
I wanted to speak about the staff and patient ratio.
Yes.
My name is Edward Obwabo from Eldoret.
Thank you.
And the issue that we are having actually that is ailing the health system, according to me, the staff-patient ratio is a big issue. Because you find like myself, I'm a laboratory technologist.
Yes.
But when I'm working, I'm having a lot of patients who are waiting. They want to be served by me, and I'm the only one in the health center. How do you expect me to deliver quality services? Even if I am well-trained, but I'm working under that kind of pressure, how do you expect that the results that I will be giving will be actually quality results? I might work hard to produce quality results, but actually when the pressure is so much, you never know what can happen because human beings are prone to errors. So I would want the government to get it right and streamline the health system in order for them to be able to help the wananchi better. Because this firefighting approach in the health service delivery is not actually helpful. It is in fact harmful. They are supposed to get the systems right. Then from there, delivery of service to the patients will be okay.
Thank you, Edward.
Thank you.
From Eldoret. Lastly, let's talk to Simon from Bungoma. Very briefly, sir. We think we've lost him, and of course, we also strapped for time. So we'll go back to a panelist to just answer these questions. And I think, Halima, you'd raise the issue of tribalism in employment as well. We've had also Edward talking about NHIF and insecurity. Yeah. We can try and tag insecurity to the issue of what we're talking about, the tagging system also. Are we still doing it manually? Right, in an era where we can have barcodes and you get all the information, just at, at the top of a finger there, are we still doing it manually? And I'm given to understand, yes, even for the patients that really come to the hospital and you don't have their names, you just write unidentified African. That's it, right? Are they serialized? Why do we have such a system where we don't have barcodes where you can get all this information, very quickly? And this issue of actually operating on a wrong patient cannot really occur if you have the proper system as well and structure. Yeah. Very briefly.
Thank you, Debarl.
Because I think this was actually coming from your department.
Yes, from our department.
So you can tell us, is it still manual?
Unfortunately, it's not even manual.
It's not even manual.
I hope that out of what has just happened, that hospitals are going to take it up immediately because it's happening in private hospitals. The idea of patient identification should be done at the first contact with the patient.
Yes.
We should have standard operating procedures for such things because in theaters we have it. But what happens when a patient has got into an accident, received in the casualty, the records, people have taken everything, but there is no identification, and the patient comes to the ward, and as Dr. has said...
So how do you tag that particular patient?
We tag based on trust.
On trust?
Yes, like you have been brought a patient, and someone read the notes and said, this is patient Debarl. So as a nurse, I'll take over that patient as Debarl.
But if I've been knocked over by a car and I don't have any identification?
Unknown, it is just unknown.
It is just unknown?
If you get 3 unknown patients, we don't have. And that's why we are saying those are systemic issues that are leading to such errors. So every hospital should have a system of identifying patients. In the advanced world, we have those codes. We have them in the supermarket. So why would we not have them in the hospitals where you have in theater at the receiving area, because all the patients come through one receiving area. the code is scanned, and if it's in the wrong patient, it blinks red,
Yes, yes.
and you return that patient. So how do you expect this nurse who is taking care of 100 patients to differentiate? Because they'll just call out the name of the patient, and they'll take that patient that has responded to that name to the theater. So the system has failed us.
The system has failed.
They need to look at it. How is it supposed, what is the right thing to do? Are we doing the right things? What can we do to change it? Because it has put us in the error. And whatever that happened in KNH was a medical error. It wasn't negligence.
It was a medical error.
It was a medical error. And medical errors happen all over the world.
But yes, we have, but I think it is multiform. We cannot say it was not a medical error, it was a medical negligence. We cannot outrule a malpractice as well. But from the nurse's point of view, you don't think it was negligence?
It was not negligence.
It was not negligence.
If the system has supported us to have the right people, where you come in and take a report probably of the 6 patients that WHO has recommended, you will not be prone to the errors. But when you're taking like 5 times the number, it's possible to
Let's say from Prof, briefly, we have to wind up as well.
The truth is, you asked a pertinent question, Debarl. We don't have a system of tagging our patients. This is handwritten, and you trust that what the patient is telling you is true. If he is John...
Even if he's bonkers, he's a madman.
And the head injured patients are all bonkers. That's the truth. So if the system as it is was not designed, Kenyatta National Hospital was designed for 1,000 patients. And every day reports are given, you have 3,000 patients. The head injured patients, all the ones who came last night, you don't have a name. Those who cannot respond to a name don't have a name. So we are blaming the wrong people. And I'm saying, Kenya, wake up. Stop blaming each other. That will not give you an answer. Identify a system that works. In the private sector, and we still work in the private sector, this is unusual. It can still occur. Like I mentioned, it occurred in Bristol in 2008. Yes. It occurred in Tanzania some few years ago. It occurs. What we should do is learn from those mistakes. And people have written volumes. Pilots have written volumes on how to avoid errors. These are errors. I'm sure between that time when that patient was operated, who luckily survived, many other head injured patients have died since that operation. And some of them will die because if you're going to have an operation in Kenyatta National Hospital, you might wait for 3 days to have surgery because the doctor doesn't, he can't do anything, the nurse can't do anything. And the other thing we need to remember is when a patient comes to Kenyatta National Hospital,
yes,
the casualty is obliged to take you, whether they have space or no space. When our referral system fails, when there is no referral system, then how do patients arrive in Kenyatta National Hospital? And it's not just those ones. The people who planned this, and we probably should establish a task force. We have put task forces for small, useless issues than this one, which involves the life and death of Kenyans. We should plan, because there is no planning. There is no referral. If you are in Bungoma and you have to be brought to Kenyatta National Hospital because of head injury, how do you come here?
Thank you.
Which patient comes here? And then the last one I'll tell you, Debarl, is that the patients who come to Kenyatta National Hospital, because I've worked there now for more than 30 years, as they arrive in Kenyatta National Hospital, it is the relatives to show them around. We don't have the people to show them around. Even familiarize. The patient doesn't even know where he is. Even the relatives don't. They're always asking, where is my patient? And they go to a clerk who tells them, because the clerk has seen 1,000 patients in one night. Imagine this clerk has seen 1,000 patients. What does it do? We need to segment our health sector.
Thank you. Maybe your closing remarks, Peterson, and also from Dr. Walter as well, briefly, very briefly.
Yeah, my closing remarks would be that we really need to do something about our healthcare system. Our resources, both infrastructural and health human resource, have not grown commensurate to the growing population and the demand for healthcare in this country.
Yes.
And there is need for leadership and governance and the financing to be able to check this.
Thank you. Thank you very much, Dr. Walter.
Yeah, thank you, Debarl. My final remarks is that let us have healthcare financed adequately, number one, so that we try to reach what was proposed in the Abuja Declaration. And then number two, let us involve healthcare providers, healthcare workers in the planning and policy and management of health. These ad hoc decisions or knee-jerk decisions based on a crisis will not solve our problems. Let us have healthcare professionals involved in the planning and management of healthcare provision. And one of the key things that we have proposed before is to allow for health service commission in which healthcare professionals will be well taken care of in a systematic and well-planned way.
Right, and briefly also, are we also falling short of the 15% that is in the Abuja Declaration, or where
we are, even in the current budget that came, we are less than 6%.
We're less than 6%?
Yes.
From what Abuja Declaration?
Yes, Abuja Declaration talked about 15%. Yes.
Wow. Okay, let's hear from Halima, very briefly.
My closing remarks would be, let's, as a country, audit ourselves as to where we are and where we want to be, and put measures to ensure that we are actually willing to provide Kenyans with universal health coverage, which is possible by adequately financing the health care and also looking at the welfare of the health workers, especially employment of healthcare workers.
Thank you. And what we failed to do today, and of course because of interest of time, is to try and, as I mentioned, to try and expound universal healthcare. Does it just mean it's about financing? But if you have financing and you don't have accessibility and affordability or quality service, then what does it really mean? I can have all the proper monies and financing, but I don't have access to that particular hospital. That is another question that we need to talk about. And of course, Prof, I know also you have an initiative that also you're doing within the counties as well. We're stuck for time, but I think we shall also call you back, you guys, to come and exhaustively talk about what you're doing also as far as putting our solitary efforts to make sure that we have a proper healthcare system in this country.